Welcome everybody. This is going to be one of those lectures where you will need to buckle your seatbelt. Now why do I say that? This is intense. This is the very basic foundation of pharmacology. So this is going to be a longer video, I am going to warn you. However, this is all super high yield information, no matter what level you're at. Whether you're an undergrad, whether you're in grad school, whether you're studying to be a pharmacist, a doctor, everybody will learn this information. And you will be tested on this information. So my goal is to give you the high yield concepts that will get you test points that will be easy to understand. Now I've been taught this information a few different times now, and my goal today is to try and synthesize everything. Every single time I'm taught it, it's taught a little differently. I'm here to give you the basics, and I'm here to present it in a way that you'll understand. So let's begin. We're going to be talking about the pharmacokinetics of things. We're going to be talking about the pharmacodynamics of things. So the pharmacokinetics is simply what the body does to the drug. So I'm going to write this out because what the body does to drug. If you Google this definition for pharmacokinetics, you'll get this paragraph answer that's pretty hazy. This is all it means, is what is the body doing to the drug? And that is going to be the pharmacokinetic side of things. Now the pharmacodynamic side of things, which we'll cover as well, is exactly opposite. So it's what the drug does to body. So how is the drug interacting with the body? So it's mediating its effects through receptors. The drug is going to bind receptors, and those receptors are going to have different pharmacodynamic properties. So we'll cover each of these. And so we're going to start off with pharmacokinetics. Now pharmacokinetics is going to be a larger topic in my opinion. Well, why is that? Because there's a lot going on. There's going to be four main points that we're going to cover. And that's going to be the absorption of the drug. Now the absorption, there's many different ways and we will get to those, but there's also, so once the drug is in your system, once it's been absorbed into your system, it needs to be distributed. So we have the distribution of the drug. Now the drug doesn't just stay in your intestines, in your intestinal cells once they've been absorbed. So where does it go? Where does the drug get distributed? And there's a lot of talking points with that as well. Next we have the metabolism. The metabolism of the drug. How do we change that drug from its inactive form into an active metabolite? How is the body going to use that drug? And then next, elimination. Elimination. How is the body going to get rid of this agent? Well, we know that we're going to get rid of the agent somehow. I mean, once we take a drug, it's got to get out of our system. And there's going to be a lot of talking points about elimination. So this is going to be a little longer of a lecture. Pharmacodynamics should go a little quicker. But remember, pharmacokinetics is how the body manages the drug. So all of this stuff, it's our body affecting the drug. Now, this is important. I can't drill this home hard enough. Pharmacokinetics is what our body is actually doing to the drug. While we're absorbing it, our body is distributing it. Our body is metabolizing that drug. Our body is eliminating that drug. Doesn't matter what drug it is, because it's our body that's affecting these drugs. Okay, so let's talk about each of these main points. Now, like I said, buckle up because this is going to be a lot of information, and if you have to rewatch these videos, Google stuff, I encourage you to actively learn. If you need to pause the video and I'm not explaining something well enough, pause the video and go to Google and look for answers, because there are plenty of answers out there. I'm just trying to present it in a way that makes sense to me, so hopefully it'll make sense to you. So we're going to start off by absorption. Now, I'm going to give you a softball early on. Absorption is going to be one of the easiest. There's really not much to talk about with absorption. Our body is going to take in a drug. and we're going to absorb it. Now there's different routes of absorption. There's going to be an enteral route. And the enteral route is going to involve your gastrointestinal system. Your GI system will be involved. So this will be, like, for example, an oral medication. So it's going through our GI system. Next, there's parenteral. The parenteral system, that's spelled right. The parenteral system involves stuff like intravenous injections or like intramuscular injections. We're bypassing our enteral system, the parenteral. So we're bypassing our GI system. Instead of putting it down into our intestines will absorb it. No, we're going to bypass that and go directly into the bloodstream, or directly into the muscle, which will go into the bloodstream. There's another route which is going to be transdermal. Transdermal, you may have heard like a transdermal patch. A lot of medications, especially time-released medications, will be in the form of a patch. So if you put a patch on somebody's skin and you may leave it there throughout the day, it'll slowly absorb through the skin. We're not going through our GI system. We're not going directly into the bloodstream. We're going through the skin, transdermally. And then lastly, we could do like a respiratory droplet, like an inhaler or a nebulizer of some sort. So respiratory. And I've already covered the models for that. Alright, like I said, this is going to be your softball. This is going to be the easy one. Enteral, GI. Parenteral, as the name suggests, it's para. It's kind of like the enteral except not. And then lastly, transdermal and respiratory, easy. Okay, now let's get into something a little more tricky. This is going to be the distribution. I'm going to change colors on you just so you're still entertained a little. We're going to be talking about the distribution of the drug. So it's just been absorbed. Somehow we have the drug in our system. Now what's our body going to do to it? And the main talking point here is going to be our volume of distribution. Now I could talk about the volume of distribution for hours. I am aware of that. What I'm trying to do is I'm trying to give you the very basics, the highest yield information to maximize your test score and to maximize your knowledge. So this is going to be your volume of distribution. It can also be called the apparent volume of distribution, either one. So there's going to be an equation involved. So we've got the volume of distribution. And that's going to be the amount of drug in body, and I say in the body, or it could be in your distribution area. So if you're talking about a specific area, it'd just be your distribution area. Otherwise, we're mostly talking about the amount of drug in the body. And then it's going to be divided by the plasma drug concentration. And that's my shorthand for concentration. So it's the plasma drug concentration, the amount of drug in the plasma. So we have the amount of drug in the body divided by the amount of drug in the plasma. So factors affecting the volume of distribution are going to be stuff like blood flow to tissues. The more blood flow you have, the more you're able to distribute this blood. So blood flow. You could have lipid solubility. Lipid-soluble drugs will get stored in fat. They'll get stored in membranes possibly. But typically, if a drug is very lipophilic, meaning they like fat, you're going to store it in fat tissues, in adipose tissues. Also, the molecular size, so the size of the drug is going to have an effect on the distribution. Then also the plasma proteins. This is probably one of the main ones I would like to emphasize. Plasma proteins. This is because if you hear a drug being protein bound, so if there's a protein drug interaction, it will be inactive. Only drugs that are free drugs, are active. This is a main point because if you have liver disease, you're unable to synthesize, let's say, albumin, which is going to be your most predominant protein in the body. So if you have albumin floating around in your bloodstream, which is going to be a lot of albumin, it'll bind up some drugs. Now, if it has a strong protein, that albumin drug interaction, that drug will not be active. So you'll need a lot of drug to be given so that way you can get your drug effect. However, let's say you have liver disease and you can't produce very much albumin. You can't produce much protein, which will bind that drug, which means you don't need to give very much drug because all the drugs that you give will be in the free form. They'll be active. So that's where the plasma proteins come in. And that's going to be a big influence on your volume of distribution. Okay, so volume of distribution, let's talk about it. It's the proportion of the drug, so the amount of drug in the body compared to your plasma volume. So it's a ratio, it's a comparison, it's a proportion. Next, we're still on distribution. I'm going to have to open up a new side. Distribution. Continued. Okay, because we're not going to be able to fit this all in. So also there's another concept that I want you to be aware of. It's going to be called bioavailability. Bioavailability, a long term simply meaning how much drug makes it into the system. So let's just percent of drug into system. Now what does this mean? Well, you have to take into account a couple different factors. You have to take into effect absorption. Now we've already talked about absorption. If you give 100 units of drug, if you give 100 units of drug X, and the absorption, you don't absorb it all. Let's say you only absorb 50% of it. Well, then you'll only have 50 units of drug X. You'll have a 50% bioavailability. But also you've got another factor, and that's going to be extraction. Extraction. This is going to be how much drug you can... So if you give 100 units and you absorb 50% of it, now you have 50 units. Now, of that 50 units, how much of that is going to be usable by the body? How much can be extracted and used? Let's say extraction is another 50%. Only 50% can actually be used. 50%. That means 50% of 50 is going to be 25. So ultimately, your bioavailability is only 25%. So you have to take into account absorption, and you also have to take into account extraction. Two factors accounting for bioavailability. So my ultimate bioavailability is the amount of the drug into the system that we can actually use. It takes into account the absorption, takes into account the extraction, and the final amount is going to be our bioavailability. So if we gave the 100 units, only 25% will be available for our biologic processes. One note is, another point, this is probably a top 10 on this whole lecture, is that when you give something via the intravenous route, what we're doing is we're bypassing this absorption. We're bypassing the extraction phase. So, intravenous dosing, parenteral dosing via the intravenous route will have 100% bioavailability. We're decreasing our first pass effect. We're decreasing our absorption limitations. We're decreasing our extractions. So intravenous administration, you'll have 100% of the drug. If you give 100 units of that drug, you will have 100 units of that drug available for use in your body. Excellent. I've also got a few more talking points regarding distribution. So let's try this again. Continued. Hopefully we can fit it all on this page and then move on to our metabolism, because metabolism is a fun one as well. Okay, so we just talked about volume of distribution. We just talked about bioavailability. Now let's talk about loading dose and maintenance dose, because your loading dose and your maintenance dose are pretty high yield topics in pharmacology. Well, why is this? What is a loading dose and what is a maintenance dose? Well, let's say you're dealing with a new patient that has never had drug Z before. Drug Z, and we've got a new patient. Okay, so they have no drug Z in their system. Our goal is to try and load their system up with drug Z and to try and get it to our target concentration. Let's say our target concentration, drug Z works best in this person at a rate of 30 intra-units here, micrograms per liter or so. I mean, make up your units. So at a rate of 30 units. When you give a drug, you want to give it a high dose. Well, why is that? We want to reach this 30 unit dose as quickly as possible. And to do such, we're going to give a loading dose. That's what the loading dose stands for, is we're trying to give a high dose of a drug so that way we can reach the peak concentration as quickly as possible. Our maintenance dose, on the other hand, is once we have some drug Z in the system, we want to keep that drug Z at about 30 units in the body, because we're going to be eliminating the drug, but we're also going to be giving new drug. So we're trying to balance the system around that 30 point. So we want it to be equal. We want that concentration to remain at 30. We're going to be eliminating some of the drug, so we're going to have to give some drug at about the rate of elimination. So that's what our maintenance dose says, is we just loaded the system, we got it to 30. Now let's keep it at 30. Let's maintain that dose at 30. So then you have to figure out what our maintenance dose is, how much drug you need to give for that drug to remain at that target concentration. So we have a couple more formulas here. I'm going to change color just so we don't get it confused with up there. It's going to be the desired peak concentration, so your desired concentration. In this example that I gave, it's going to be 30. So I'm just going to say peak concentration. Also can be desired concentration, or like your target concentration, times your volume of distribution. So remember your volume of distribution formula, that's going to be the amount of drug in the body divided by the amount of drug in the plasma, divided by bioavailability. Now we're dividing it by bioavailability because if you have a really low bioavailability, if let's say only 10% of the drug that you're giving is going to be bioavailability active, I mean, you really don't absorb it all, and you don't extract it well, then you're going to have a low bioavailability. So that's where the bioavailability comes in. Otherwise, what's really important is your desired concentration times your volume of distribution. If you have a really large volume of distribution, you'll need drug to meet that, and you'll need your peak concentration, or your target, your desired. In this case it was 30, and then I made up a unit, 30 units desired in the body. So that's going to be your loading dose. This is really important. So it's going to be affected. No, we'll cover that at the very end once we've talked about maintenance dose, because I think that would fit in a little better. Sorry, I'm talking to myself. I must be crazy. So let's talk about maintenance doses. This is going to be your peak concentration. So you're just like above. It's going to be another formula. So you've got the peak concentration, this desired concentration. So again, our 30 times. Now instead of volume of distribution, because the loading dose dealt with our volume of distribution. If we have a high volume of distribution, we need to get drugs in a higher dose so it'll meet that higher volume of distribution. However, for the maintenance dose, remember I said it deals with clearance. We're trying to clear the drug and give the drug at approximately the same rate, so that way we hit our peak concentration. So it's going to be peak concentration times the clearance. Now, we haven't covered clearance yet, and I'm aware of that. I don't think it's really important right now for us to hit it, because that deals with the elimination. Remember, there was absorption. Now we're in the distribution. There is also metabolism and elimination. Clearance, I think, is going to fit in a little better in elimination. Just know that our maintenance dose deals with the amount of drug we put in versus the amount of drug we get rid of, so the clearance, and we're trying to teeter-totter it around this peak concentration time. Then again, it'll be divided by bioavailability, blah, blah, blah. So the bioavailability again, if it's 100%, if it's an IV drug, you can get rid of this because it's 100%, so you don't have to worry about it. So now let's talk about kidney disease. So in kidney disease, if you have end-stage renal failure, what you'll be doing is you'll be knocking out your clearance ability. You'll have your clearance capacity go way, way down. So if you have your clearance capacity go down, more of that drug is going to stay in your system. So if kidney disease, you'll need to change your maintenance dose. Now, why would you need to change your maintenance dose? It's because you're not able to clear that drug very well, so you don't need to give as much to teeter-totter it around your peak concentration, your target concentration. So that makes sense. If your clearance goes down, you can decrease your maintenance dose. And again, how does kidney disease affect the loading dose? Well, like I said, you have this person here, and they have 0 drug Z in their body. If they don't have any drug in their body, you're still trying to hit that same peak dose. And look here how clearance doesn't make its way into this equation. It's the volume of distribution. So if you have kidney disease, the loading dose will stay the same. It's because you're still trying to get that peak concentration into the bloodstream. You're giving it at such a quick rate, like a one-time loading dose, that you're not dealing with clearance. You don't care about the clearance. That's only for the maintenance of it. So if you have kidney disease, your loading dose will stay the same. If you have kidney disease, your maintenance dose will decrease. Okay, so that has a lot to do with the distribution. We talked about the volume of distribution, we talked about the bioavailability, then we talked a little bit about loading doses and maintenance doses. Remember, I'm just hitting the very high yield stuff, the most important stuff that I think you should know for your maximizing test points. Now let's talk about metabolism. So we're still talking about pharmacokinetics, what our body is doing to the drug. And what we'll be doing is we'll be metabolizing. We'll be taking drug X, turning it into active metabolites. And then eventually we'll turn it into inactive metabolites. So we're modifying this drug into its active and then inactive form. So how are we going to do that? Well, there's things called reactions, and there's 2 different types. There's going to be phase 1 reactions. There's going to be phase 2 reactions. Now, we're transforming this drug, this molecule, into its metabolites through these reactions, phase 1 reactions and phase 2. Now, phase 1 reactions are going to involve 3 primary processes. And that's going to be, let's change colors here, it's going to be oxidation reactions, reduction reactions. Your favorite, I know you love oxidation reduction reactions. And then also hydrolytic, stuff that breaks down water reactions. How are we going to do this? It's going to be through our CYP 450 system. 450 system. Our CYP 450 system in our liver. Now, where do we see this? This is going to be in zone 3 of our hepatic acids. If you've learned it, this should bring back a little bit of nightmares. If you haven't learned it, just remember it's zone 3. There's 1, 2, and 3 of our hepatic acinus. Now there's the classic lobule, the hepatic lobule, and then the hepatic acinus, different architectures, my apologies. Zone 3 is going to be furthest away from that hepatic triad, but it's going to be closest to the central vein. Zone 3 is going to be our CYP 450 system. This is where we're going to modify drugs. And modifying drugs is our metabolism that we're talking about right here. So our phase 1 reactions are the oxidation, reduction, hydrolytic reactions, and they all deal with the CYP 450 system. Now what is the goal of this? Our goal is to make polar molecules that are going to be water soluble. So polar water soluble molecules. This polar, so we're exposing like a polar functional group on that molecule on this drug, making it more water soluble. Now there's phase 2 reactions. I'll put this in white so we can separate it. There's phase 2 reactions. There's going to be, like we had up here, there's kind of like key buzzword types of reactions. There's going to be key buzzword reactions for type 2. Glucuronidation, for example. We're going to see acetylation and sulfation. There are others. These are the 3 highest buzzwords: glucuronidation, acetylation, and sulfation. What this is doing is we're going to be converting it into inactive metabolites, most likely. Now there are exceptions to everything I say, like maybe your drug that you're given is already active metabolite. However, in most instances, our phase 1 reaction is going to make our active metabolites. We're going to expose that polar functional group, we'll make it water soluble, it'll be an active metabolite, and for the most part, phase 2 reactions are going to maybe give us inactive metabolites. And then these inactive metabolites will be excreted, and that'll be through the elimination part of our pharmacokinetics. So we haven't touched upon that yet. I'll leave that alone. So this is our transformation phase, how we're transforming a drug into its active metabolites. Now there's an effect, and it's called, so we're still on metabolism. We're still on the metabolism part. There's an effect called the first pass effect. I'm going to star this. Why? It's because it's a top 10. Everybody loves to ask about the first pass effect. Everybody loves to ask about the first pass effect. Why is it? It's because it's going to be your liver encounters drug before it enters the system. Now you'll see this with your enteric absorption, enteral absorption. So if you take a pill orally, it'll go through your GI system, it'll go into your intestine. And it's really important that we kind of draw this out. So here's our intestine. It's going through our intestine. I have no clue what that is, but that's going to be our intestine. It is going to get absorbed. So from the intestine, it's going to go to our portal circulation. You can tell that I am not an art major. That's because that is not an intestine, but we are going to say it is. So our intestine, drug gets absorbed, goes to our portal circulation. Now remember, the portal circulation is going to be the circulation that's connecting our intestines, so like our small intestines, to our liver. Now why is this? It's because then our liver can have first pass effect. And that'll do is it'll drain in the portal circulation, it'll go to the portal, or the hepatic portal vein. The hepatic portal vein. I have a really good video on the liver architecture. I'd really recommend that if the liver is kind of hazy to you, if you haven't learned it very well, the liver architecture video is going to be a great place to start. It'll kind of talk about the zones that we talked about. It'll also talk about the hepatic portal vein. But what it is we're going to go from the portal circulation to the hepatic portal vein to the central vein. And from that central vein, we'll leave via the hepatic vein. And the hepatic vein will eventually drain into the inferior vena cava. That inferior vena cava goes to the heart, and from the heart you go to your body. Now this is important. So we started in the enteral absorption. We took an oral pill, an oral drug, that'll go down through your stomach. It'll go to your small intestine and get absorbed. We go into portal circulation. Finally, this right here. This is where the drug will encounter our liver. Now, it'll encounter our phase 1 reactions. It'll encounter our phase 2 reactions. It'll go metabolism. It'll undergo metabolism here in this step, where we go from the hepatic portal vein to the central vein, and to do that it must cross liver cells, and those liver cells will be active. And then it'll go finally whatever's left, whether it's the active metabolite or the unchanged drug. I mean, the liver can't do it all. They can't affect all of the drug, but it'll affect some of the drug, and then it'll go to your hepatic vein and then to your body. So the first pass effect is simply the liver encounters the drug before it enters the system. Now this has to deal with bioavailability. Now it deals with bioavailability because you'll have a decreased bioavailability if your liver encounters it first. So we're kind of synthesizing stuff together now. If we have a first pass effect, it means that our bioavailability for that drug may be a little decreased because we're not able to extract everything. Now, remember that the first pass effect, if we're getting rid of some of that drug before it becomes useful, that's not good. Our target is we want all of that drug to be useful. However, the first pass effect, our liver encounters it first. Okay, so if we give it via intravenous route, so IV route, we're going to bypass this first pass effect. It's because if we give it IV, it'll go directly into our body, directly into the body. We don't have to go through the portal circulation. We don't have to go through this whole pathway. IV will go directly to the body. So that's an important concept. So hopefully you're paying attention, and I want you to restrap in your seatbelt. I see some of your seatbelts have been unbuckled. This is a time where you're going to need to restrap in, because this is where it gets hairy again. The elimination. So now we are on our fourth concept. I'm going to go here. We talked about absorption. We talked about distribution. We talked about metabolism. Our body has done a great job so far affecting this drug through pharmacokinetics. However, now you've got elimination. Elimination is a big one. Big one. Star on it. Okay, so elimination. There's a lot to do here, so pay attention. Very basically, we can eliminate drugs or metabolites of drugs through two routes, through the kidney or through the GI system. And the GI system through the feces, such as like bile, and we'll get rid of it through excrements. The kidney, on the other hand, will get rid of it through the urine. Good. So, simple, right? No, can't be simple. We've got to make this harder. So, the bottom line is we get rid of stuff through the kidney or the GI system. Now, we're primarily going to talk about the kidney. That's a major player. So there's going to be another equation. I'm just going to get to it right now. We've already talked about it. It's clearance. I've given you a few formulas. Here's another one. Clearance is going to be the elimination of the drug. Elimination of drug divided by the concentration of the plasma drug. So the concentration of the drug in the plasma divided, or the elimination of the drug divided by the concentration in the plasma. This is going to be an important concept. Also, you can work this out a different way. Clearance is also equal to the volume of distribution times your elimination constant. K for constant, so your elimination constant. And your elimination constant is going to be also equal to clearance divided by volume of distribution. So just remember, this is just a reworking of this formula right here. So this is nothing new. This is nothing special. You don't even need to remember it. However, it's just a reworking of this equation here. What I would put to memory is clearance is equal to the elimination of the drug divided by the plasma concentration. So if you increase the plasma concentration, you're going to decrease the clearance of the drug. Okay, so let's throw in more formulas. I like to get all the formulas out, and then we can play with them. We can talk about them. So there's also going to be something called the T-half. So the half-life, the time it takes to get rid of, to eliminate half of the drug from the system. So your T-half-life will also have a few different formula variations to it. So I'm going to get rid of this because I need the room. I'm trying to get all the formulas on one page, and that way we can talk about kind of the concepts later on. So our T half-life, our time it takes to get rid of half of the drug. So if we have 100 units and we have a half-life of 50 minutes, let's say, because this is time in minutes, if we have a T half-life, if we had 100 drug to begin, it simply means it takes 50 minutes to get to 50 units of drug. So let's work with this. T half-life is the amount of time for to get the drug to half concentration. How much time is it going to take for us to eliminate the drug so that way the drug gets to half concentration? If we started with 160, how much time does it take for us to get to 80 units of that drug? If we started with 90, how much time does it take for us to get to 45 units of that drug? That's all we're saying. That's all our T half is saying. How much time does it take to get half the concentration of that drug? Now our T half life is, we've got formulas. So it's going to be 0.693. Some people round it to 0.7. Depends on your professor. It depends. That's all I can say. So 0.7 times volume of distribution divided by clearance. Okay, what else does this mean? Or we could just do 0.693 or 0.7 divided by our elimination constant. Remember, our elimination constant is just a reworking of our volume of distribution and clearance. So this is pretty much the exact same thing right here. It is the exact same thing. However, it's just a little bit of a reworking. So this is the formula that you should really commit to memory, because if you know this, you'll be able to extrapolate into our modified version of this equation. Okay, so we've got our half-life. Now I do want to point out that the longer the half-life, the longer the time it'll take to clear that drug. So our drug, so the increased T half-life, so our increased half-life time, the more drug we'll have in the system in the long run. We're not able to clear it as fast. The more drug will stay around for longer. If we have a really short half-life, it means our body's going to clear it very fast. Also of note, it'll take 5 half-lives, T half, to accumulate blood in the system. So if our drug has a really short half-life, here, I'll finish my writing and then I'll explain it. So 5 times T half-life, accumulate or get rid. So what am I saying by this? It'll take 5 half-lives. So 5 half-life for the drug to either get to pretty much full accumulation to our target dose, or to get rid of the drug for the most part. Now let's talk about this. Well, it's easier to get it if we talk about the getting rid of part. So 5 T half to get rid of a drug. We have to go through 5 half-lives to pretty much get rid of a drug. So let's talk about this. Let's say we have 100 units of a drug. If we have 100 units of a drug and we go through 1 half-life, I don't care if it's, let's say it's 1 second. Super short half-life. So after the first second, we'll have 50 units of drug in the system. 1 more second goes by, because we're just assuming that T half-life is 1 second. If we're assuming it takes only 1 second for a drug to have. After 1 second, you'll be at 50 units. After 2, you'll be at 25. After 3, we'll be at 12.5. After 4, we'll be at 6.25. And after 5 seconds, we'll be at 3.1. Is that 25? Probably did that wrong, but so what I'm saying is, and then beyond that, we're at such minute amounts that, I mean, we're at less than 5%. We're at less than 5%. We're at about 3% after 5 half-lives, which pretty much means the drug is now out of the system. So when I say, I'm going to go back, when I say it takes about 5 half-lives to get rid of a drug, I'm simply saying if we immediately stopped giving a drug to a patient. So we kept him on a maintenance dose, and we kept that maintenance dose at about 100 units in the body. So we have our little person here. We're trying to keep them at a drug concentration of about 100 units in the body. We completely go cold turkey. We cut him off of the drug because we want to switch him over to another drug, but before we switch him, we have to try and get rid of this drug first. So what do? Well, we figure out the T half time. And we figure out the T half time of that drug because that'll be an inherent characteristic, and then our body's going to modify it. So we're trying to figure out the half-life of that drug within the body. And we need to wait at least 5 half-lives before that drug is out of our system. So we wait, in this instance, which is not true in real life, the T half-life is going to be 1 second. Sometimes the T half-life can be a full day. It just depends. Sometimes it's short, sometimes it's long, depends on the drug. Okay, so we've got our T half-life of 1 second. Our maintenance dose kept it at about 100. We go cold turkey. After 5 seconds, the drug is pretty much gone from the body. And for our sake, the drug is going to be out of the system. So anywhere from like 4 to 5 to 6 half-lives. The key is, I would say, 5 half-lives. And that's what most people say. Okay, beat that one to death. Now let's move on to elimination first order versus second order kinetics. So we're still on the elimination. Still can't be done with it yet. However, we're getting there. We're so close. This is the finish line. This is the sprint. I used to be in track. I was not a sprinter. But this would be the last 100 meters if we're running a distance race. So what we have is we've got first order kinetics, and we've got zero order kinetics. And we're talking about elimination. So first order elimination kinetics versus zero order elimination kinetics. Let's start with zero because I think it's easier to kind of wrap your head around. It's just going to be a constant elimination. That's all it is we're going to constantly get rid of the drug at a certain rate. So if we're getting rid of the drug at 10 units per minute, it doesn't matter how much drug is in our system, we'll get rid of the drug at 10 units per minute. So if we started with 100 units, it'll take 10 minutes to get rid of 100% of the drug. Hopefully that should make sense. It's very basic. It's at a constant rate. If you have 100 units of drug and we get rid of it at 10 units per minute, it'll take 10 minutes to get rid of 100% of that drug. So we'll have 0% left over. Now this is easy. Now What's the rule in medicine? If it's easy, it probably doesn't show up very often because medicine is never easy. Yeah, that's the case. I think that's the rule. So what drugs, let's get rid of this. What drugs are dealing with zero order kinetics? Well, there's going to be 3 or 4 primary prototypical drugs that are going to be dealing with. And this is going to be phenytoin. This is going to be a big one. I would star this. This doesn't go in my top 10, but this is important to know because I have had multiple questions now that say, which of the following drugs undergoes zero order kinetics? And they'll list a whole bunch of drugs, and then they'll throw phenytoin. You have to know that phenytoin goes at a constant rate. Constant rate. Also, you've got aspirin, so like the salicylates. Also, alcohol. Alcohol is a big one. So ethanol, alcohol. Probably I'd start that one too. These are the 3 big ones. You've also got some more like theophylline. Not that important. These are your big ones. I would commit that to memory if I were you. I would know that zero order kinetics follows these 3 drugs. These are going to be your prototypical drugs for zero order kinetic elimination. So we're getting rid of these drugs at a constant rate. Doesn't matter how much drug is in the system. We could have 1,000,000 units. We could have 1,000,000,000 units. We could have 1,000,000,000 units. It doesn't matter. We're going to get rid of it at this constant rate. And it's not always going to be 10 units per minute. It could be any constant rate. Okay, now let's talk about first order. I saved it for its own slide because this is a little more tricky. First order kinetics are going to be dependent on the drug concentration. They're dependent on drug concentration. Dependent on drug concentration. Remember it. So what does this actually mean? In English, it means the more drug we have. So if we have a higher drug concentration, we'll have more elimination. Now, we don't have like a certain amount. It'll be different for each person. It'll be different for each drug. However, just know that the more drug that you have in your system, the more it'll be eliminated. So that, likewise, the less drug you have, the less elimination. The same could be said. Now, this is related to your T half-life. So if you have a long T half-life, you're going to have a lot of drug in your system. You'll eliminate it more. However, if you have a short half-life, then you won't have very much drug in your system, meaning you're decreasing your first order kinetics at a faster rate. Hopefully that made sense. Just erase what I just said. It doesn't really make much sense. I didn't explain it very well. My apologies. So now let's talk about this. Here we had 3 drugs. Pretty much I'm going to say all else. Now I said medicine wasn't easy. Medicine's never easy. Those 3 drugs will be the easy route. Pretty much everything else deals with first order kinetics. Let's talk about the accumulation. So this is getting rid of it. If you're getting rid of it at a constant rate, but you're on a maintenance dose that exceeds this constant, so if you're getting rid of it at 10 units per minute, but you're dosing it at 100 units per minute, what you'll have is an exponential accumulation curve because you're able to get rid of it at a constant rate. Now, I should probably make this into a graph, shouldn't I? So let's make it into a graph. Let's see if I can. Me and graphs don't mix well. However, so drug concentration down here. This would be rate. Oh, my apologies. Nope. That's why I stay away from graphs. Okay, this would be time. This would be drug concentration in the body. Okay, so as time goes on for zero order kinetics. Now I said that we're getting rid of it at a constant rate. So we're getting rid of it at a constant rate. It doesn't matter how much drug is in our system, we'll have a linear elimination curve. Because as time goes on, we'll have a linear slope because our constant elimination. We could have a million, just a bajillion, I think that's terrible attempt, that's 10 million. Okay, so we have 10 million, we could have 1. We'll get rid of it at a constant rate. However, let's take a look at first order kinetics. First order elimination kinetics. Same graph here. I can reproduce it this time since I didn't mess up. So drug concentration. Let's start at 100. Let's work our way down to 0, and time doesn't really matter. Time as long as we're moving on. Now if we have a lot of drug, like I said, we'll get rid of it at a fast rate. However, as our drug concentration goes down, we're not able to get rid of it at such a fast rate. So we start out at a really fast rate. We have a lot of drug, we have 100 units in our system. However, as time goes on, we're decreasing our drug dose. That decreased drug dose means we can't get rid of it at such a fast rate. So let's take a look back here. Depending on the drug dose, the more drug we have, the more elimination. Does that fit? Yes, it does. The more drug we have, the more elimination we have, and the lesser drug we have, so once we're down to kind of like the remainings, the leftovers, we don't get rid of it as fast. It takes more time to get rid of it. Okay, so that was some of the basics of pharmacokinetics. If you have any questions, let me know. This was a lot of stuff, but we did talk about a lot. We talked about what pharmacokinetics basically is, but then more importantly, we talked about the 4 main high-yield topics of pharmacokinetics. We talked about the absorption and the different routes of absorption. We talked about the metabolism, or the distribution. We talked about the bioavailability, the volume of distribution. We talked about the loading and the maintenance dosing. We talked about some good stuff. We also talked about the metabolism using phase 1 and phase 2 reactions. We talked about the first pass effect. We talked about what the drug is going to be, or how the drug will be affected. And then lastly, we talked about the elimination. The elimination really deals with first and second order kinetics. Also deals with clearance. Clearance is going to be one of those equations that you just have to commit to memory. Why? It's because it's important. That clearance equation is going to be how our body gets rid of the drug. And we saw that clearance in multiple aspects. We saw that clearance in our maintenance dosing, and then we also saw it in our clearance and our T half-life equations. So if you have any questions, be sure to ask. You can unbuckle your seatbelts for the time being because the next lecture, the pharmacodynamics, is a little easier. And it's a little easier to explain. It's a little easier to understand. There will be some graphs. We'll have some fun graph time. Otherwise, if you found this video useful, please click like and subscribe for more great videos. Thank you very much.